Thank you for joining us for today's Resource and Wellness webinar, Diabetes and Foot Care, in collaboration with the American Diabetes Association. Today, our experts will discuss how chronic diseases like diabetes can affect foot care. My name is Dr. Daniel Corboy, and I am the Chief Medical Officer for the Humana Illinois Medicare Medicaid Alignment Initiative, also known as MMAI for short. MMAI is a health plan program for people who are dually eligible for Medicare and Medicaid. This is a voluntary program that improves health care for dually eligible beneficiaries in Illinois and allows them to receive all their health care services through one managed care plan. MMAI is now available statewide in Illinois. This expansion means that all Illinois residents who are eligible to receive Medicare and Medicaid coverage and benefits can enroll in this health plan. As we continue this expansion statewide, we strive to be present in the community to break down barriers in communication between members, community groups, provider groups, and managed care organizations. Our goal is to decrease confusion and provide services in order to best serve our new members. The Resource and Wellness Series with the American Diabetes Association brings live, interactive webcasts throughout Illinois. Quarterly, Humana and ADA content experts host a webinar focusing on a range of topics. All live sessions and online resources are recorded and available in a virtual library for access and continued learning by members at their discretion. This library can be found on the ADA of Illinois website. Thank you for joining us for our second topic of this year, and we look forward to seeing you for future topics.
Hello and welcome to our second Resource and Wellness series sponsored by Humana. We are thrilled to have Dr. Zamata here from the University of Chicago, as well as one of her patients, Mr. Flores, to share with us today about diabetes and foot care. And I believe Dr. Zamata might be having some technical difficulty. I don't know if she's been able to resolve those yet. Looks like they're gonna do a little sharing.
We're gonna do some sharing because I can't get the pictures yet, but we can at least start talking and get into it.
Yeah. So what I'm gonna go ahead and introduce Dr. Zamata and read a brief bio. Dr. Ann Zamata is originally from Buffalo, New York. She received her undergraduate degree at Canisius College, then came to Chicago for medical school. She received her DPM degree, which is the Doctor of Podiatric Medicine, from the School College of Pediatric Medicine in 1991, and went on to complete her residency at Heinz and Loyola University Medical Center. Dr. Zamata later became a board-certified surgeon with the American Board of Foot and Ankle Surgeons. Her career started out in private practice in Illinois, but as her love for diabetic foot care increased, she knew she needed to work in a university setting. In 2000, she joined the faculty at the University of Chicago and has been there ever since. Dr. Zamata holds the title Associate Professor in the sections of Vascular Surgery, Orthopedic Surgery, and Endocrinology. Since that time, she has grown her practice to almost exclusively diabetic foot care and limb salvage. She is also the co-chair of UCHAMPS, which is the University of Chicago Amputation Prevention Program. Dr. Zamata lives in Chicago and has been married for 30 years this year and has 2 adult children. Thank you for joining us today, Dr. Zamata.
Thank you. It's nice to be here. As Rebecca had said, I've been at the university now for 22 years, and my passion is diabetic foot care and limb salvage. That's why I was excited to have the ADA invite me to speak. So thank you very much for the opportunity.
Well, thank you. Well, let's go ahead and jump right into some questions. Tell us a little bit about what is a podiatrist and why should somebody living with diabetes go see a podiatrist such as yourself?
Absolutely. So a podiatrist is a doctor of podiatric medicine. We go through 4 years of medical school, and then we also go on to residency programs. So we are actually board certified to do surgery of the foot and ankle, and we treat all types of problems with the foot and the ankle as well. The reason why you want a diabetic person to see a podiatrist is because a lot of the complications that occur in diabetes occur in the foot. We have some of the scariest complications like loss of limb that can occur in a diabetic. So by seeing a podiatrist just to get yearly checkups, we can actually tell you if you're at risk, if you are low risk, and we can also give you a lot of information to prepare yourself for when you leave our office to prevent bad things from happening. So we usually like to see our diabetic patients at least once a year. If you are a high-risk diabetic, then we would see you more frequently.
Thank you. Tell me a little bit about what one of your patients can expect during a podiatric exam.
Sure. So when we do a podiatric evaluation of our diabetic patient, we usually go through a 5-step process. We'll initially start looking at your circulation, because circulation is actually one of the areas in the foot that get affected by diabetes. So we will palpate your pulses. You have 2 pulses, just like you have one in the wrist. You have one on the top of the foot and you have one by your ankle. So we can actually palpate and make sure that we feel some pulses going in there. Now, if you can't feel a pulse, it doesn't necessarily mean that you have something bad going on. If you have swollen feet or ankles, a lot of times we can't feel that pulse. And then we check for other indicators. So if I see hair growth on your toes, then I know that we are getting good circulation into the toes. And don't forget that the toes have small vessels. So we can't palpate a pulse in your toes. Now, not everybody has hair growth on their toes. So if you don't have hair growth, again, we can just check and see if your toes are nice and pink. Are they warm? We touch your feet to make sure that they're warm. If we see a foot that doesn't have any pulses, it's starting to look gray and dusky, it's cold, you complain to me about pain when you're walking, then we will start looking into that and going into ordering blood flow studies and things like that. So that's one of the big things we do. The next thing we do is we check your nerves. So we use a little filament that will tell us if you can feel the bare minimum that we want you to feel. Pain is very protective. It's actually a good thing. It tells you when something's wrong. So if you can't feel my touch or my touch of the filament, then I start to question if the diabetes has been damaging the nerves. When you have high blood sugars, things that go over 150, hemoglobin A1Cs that are approaching 8 and 9, these are very elevated blood sugars, and all of that sugar has to go somewhere, and it can actually affect the sheath of the nerve, which damages the nerve, and that's when people will start feeling things like numbness and tingling and stabbing and shooting pains, and that's something called neuropathy, which I'm sure we'll talk about in the future. So we do screen for that as well. Then we like to look at your feet. Do you have bunions? Do you have hammer toes? Do you have any foot deformities that might increase irritation or pressure from a shoe? And then we can kind of guide you on what shoes to wear, how to prevent you from getting blisters, things like that. Next, we look at things like your walking. So patients who are diabetic, who have very bad neuropathy, sometimes lose their balance. We can evaluate that. If you've had a stroke and you have a drop foot or a different type of walking pattern, we can guide you there as well. So we go through all of that. And then we also examine your skin. Do you have any open wounds? Do you have any sores? Do you have any thick calluses or corns? Because these things can put you at risk for developing problems later. So a lot of times we can debride those, shave those down for you. If you have thick fungal toenails, we can trim those for you as well. Just take care of the feet so that we prevent any problems from occurring. And then we also go over some lifestyle things like increasing exercise, watching what you eat to control your blood sugars. And so we do a full exam to make sure that we catch everything.
Yeah, it sounds like that's very thorough, of course. You're checking for a lot of different aspects for a patient's foot care. But you did mention something about numbness and feet. Tell us a little bit more about that and what that means to somebody living with diabetes.
Sure, and that's actually one of the areas in the foot where we actually diagnose diabetes. So if you've never been diagnosed with diabetes and you are starting to get numbness and tingling in your toes, typically that could be a sign that you are diabetic. So anytime those blood sugars go over 150 to 200, we're going to see all that excess blood sugar affecting the nerves. When that happens, the nerves will kind of misfire. So you're not going to get nerve signals and normal nerve responses, and you'll start feeling some really obscure feelings. So sharp shooting pains, stabbing, some people feel like things are crawling on their feet. And these are all things that occur when the blood sugars are starting to damage the nerves. Now, diabetes is not the only reason why people can get damage to their nerves. If you have any back issues, certainly you can develop things like sciatica, which will also give you similar presentation in the feet. People who drink too much, they can develop damage to their nerves, and chemotherapy can cause numbness and tingling too. So we do rule out everything before we kind of go right towards diabetes. But if you do have issues with your nerves, that is something called diabetic neuropathy. And we usually will see this in patients who have had diabetes greater than 10 years. We'll see this in patients who have blood sugars that are poorly controlled, or we'll even see this in patients that have very high fluctuations in their blood sugars. So, at one point in the day, you're at 400 and then you drop down to 80 or 70. These things are also the things that cause damage to the nerves. Now, are these permanent? They can be, the longer that you have issues with the blood sugars affecting the nerves. Is there a way to treat this? There's really not a cure for diabetic neuropathy, which is why we really want to prevent you from getting that. Now, you can have some neuropathic responses to high blood sugars. So if you get some numbness and tingling in your feet and then it goes away, that might not be permanent. That's just a response to those elevated blood sugars. If you have back pain with it, hang on one second. I'm going to mute this one and I'm switching.
You have to love technical difficulties on Zoom. So thank you for your patience. I know Dr. Zamata wanted to share some slides with us today, and I think that is what she is working on, getting her computer and those slides to come up. So I want to be sure to give her a little bit of time here to get that worked out if she's able to.
Okay, I'm going to go through here for now, but I think we might be able to share my screen on the other one so that we can show some things for you guys. So I do apologize for that. Way better podiatrist than I am computer guru. And one of my patients will attest to that.
Saved my leg.
This is just kind of the world we live in.
Yes, it is. So, but I also think that I will be able to share my screen. So if we can do that, can I try?
I think you're sharing.
Perfect. So then I'm going to get to what I actually wanted to show you guys.
So now they can see. I'm gonna slide over here. So let's see.
But then I want to share like something from my PowerPoint.
Okay. To the PowerPoint right here.
Here we go. Okay. All right. Thank you so much for bearing with me. So we were talking about neuropathy. Thank you, Dr. Lance, another one of our podiatry staff here at the university. So we were talking about neuropathy, and what this picture is showing you is that monofilament that I talked about. This is what's called a Weinstein filament, and we use this filament to check your sensation to make sure that you can feel. And again, this is the absolute.
Dr. Zamata,
Yeah.
I don't think we see your screen.
Oh, you can't. Okay. All right, then.
Why don't you stop sharing and try again?
Okay, we can do that. Let me get out of this. Okay, so now we'll try again. Can you see us now?
I can see the two of you. Yes.
Through here. I think that's through this one and not this one. So let me see. Hang on. All right. Well, I don't want to waste any more time. I don't think it's working. So I don't know what to say here, except I'm sorry.
We have a lot to talk about. And of course, love to finish that conversation about neuropathy and, the treatments, and there is a treatment.
Yeah. So what I was alluding to was, so there's not a real cure for neuropathy, but if we catch it at a point where it's just a symptom of your elevated blood sugars, there are things we can do. So one of the easiest thing is a vitamin B complex. B complex contains B6, B12, and folic acid. And these are vitamins, they're water soluble, you pee them out so they don't interfere with other medications that you use, and they're good for nerve health. If that doesn't work, there are also topical things that we can use, like capsation. These are ways that will kind of numb it when you rub it on your skin. Again, very safe things that you can do. One of the other things that you can do to help with neuropathy feelings is exercise. So studies are showing us now that walking isn't only good for your circulation, it's actually very, very good for nerve health. So you don't have to run a marathon. You don't even have to walk 20 miles. You just need to walk maybe 20 minutes a day. And you can even start out at just parking far from the grocery store. It doesn't take much, but it will help with the nerve function. And then if those things don't work, there are medications that we can give you that will help calm the symptoms down. They will not cure them, but these medications, and they're things like gabapentin, these types of medications will actually decrease the symptoms that you're feeling. And the problem that we have with these, though, is they affect your musculoskeletal system. So you can actually feel very tired on these. You can feel drunk on these. So we tend not to prescribe them unless you're really having a lot of pain. But normally, if you get your blood sugars down, we can actually get those nerves to calm down as well. Now, it might take you about 6 to 8 months for the nerves to calm down, but you'll see as time goes on that they will function better. And you'll have less symptoms and less pain. So if you are experiencing numbness and tingling that is starting at night, it's on both feet, that's definitely could be a sign that your blood sugars are elevated. So if you don't check on a regular basis, that might be a reason to check. And then if you are having problems, then you should absolutely see your podiatrist so that we can determine whether or not you have good sensation. Because if you don't feel, again, I said pain is a good thing. If you can't feel, if you step on something, a lot of times what happens is you step on something and you don't realize you did, you cut yourself, you don't even realize it until you smell it. And at that point, that's an infection and we have a problem. So sensation, pain, those are very important. And then we can always check that out and rule that out if you're having problems. And if you don't know you're diabetic, we can actually check you for diabetes too.
That's awesome. Thank you. And I think this would be a perfect time to introduce Mr. Flores. And if you wanted to take a moment to introduce him to the audience and ask him a few questions, as he is one of your patients. And
yeah, so this is Ulysses Flores. You can take your mask off if you want. So Mr. Flores initially came to me through the hospital.
Yes.
He had a diabetic foot infection, and he's been with me ever since. And he's had a long, hard road, but we're getting there.
Yes.
So I'm going to actually let him give you a little background of what happened to him.
Well, I got a cut on the bottom of my big toe, my right foot, and being the self-sufficient person that I try to be, I put alcohol on it, iodine, all kinds of stuff, and the infection got worse and worse, and then it got dark. So my primary doctor told me to come to see Dr. Zamunda, and she told me I had gangrene. And when she told me I had gangrene, she told me that unfortunately she would have to amputate my toe, because at that time I was borderline diabetic, but didn't realize that my diabetes was already, my A1C was at 12, which I didn't know at the time until I was diagnosed by Dr. Zamunda. And that caused the infection to get worse because of my high blood pressure in my system, and the infection spread even quicker. So after she took off my big toe, because actually she originally they told me I might be a candidate for under my knee amputee, which I was really scared about, really, nervous about. But she actually said, let's try to take off the toe that it's really infected. There's no hope for it. So we went through that stage, and unfortunately, I still, my diabetes part, my sugar level wasn't going down quick enough. So the infection spread to my other toe. And so unfortunately we had to go to toe. And at the end of the rope, she had to amputate all of my toes to make sure the infection don't pass all the way to my foot, and then to my ankle, and then all the way to my knee, which that's why I said she saved my leg. Yes, I'm missing some toes, but I still have my legs. Right now I'm still trying to control my diabetes. It fluctuates from 100 to 140. And
that's very, very good.
and I think about 3-4 months ago, I was my blood was they gave me another blood work, and my A1C went down to 7.5. I still have a way to go. I wanted to go even lower than that. I want to go at least at the most 7, maybe 6.5. But considering that I was at 12 and went down to 7.5, she was really happy about it. I was really happy about it. And she actually was right about the nerve damage. At one time, I even was complaining that I feel like shock. It's like somebody was shocking me in my legs. Okay. And they gave me, of course, medication for that. And after, I guess my blood sugar went down enough, the shock stopped. I didn't get no more shocks anymore. There's a little bit of numbness on the tip of my toes, but not to say that it's really, really bad on my left foot. There's no numbness on my right foot, but there's no toes there to have numbness. So, but I do still feel on the bottom of my foot on my right leg. She does test me. She goes, do you feel this? Do you feel that? Do you feel that? Yes, yes, yes. And it's not really cold, but it's not really hot. I do have warmth down there. They check my blood pressure down there, and my heartbeat, and they can hear it fine. They were going to put a tube up my leg to open up my veins. Didn't have to, because I was getting better as far as the diabetes was going. Like I said, no more shock on my legs anymore at night. Before I couldn't sleep because of the shock. It was like somebody was actually putting some batteries on my feet and just shocking me. And that's actually almost completely gone. Once in a great while when I have a pizza, it festers a little bit, but then I go back and drink some more water and watch my diet, and it goes back to what I consider now normal. I still have a little problem walking on it. I'm not used to it yet, and I've always had problems with my feet before even this. So now I'm still trying to get better. I'm still trying to get back to my old self. I do walk a little bit, not as much, but I do walk around the block with my dogs, and then I go home and rest. Especially in these hot days, I don't want to walk too much. I don't want to, get,
Right.
because I also high blood pressure. So that's.
So prior to going to the hospital, when you had the cut on your foot, did you have some of the symptoms that Dr. Zamata was talking about? The numbness.
Yes. Yes, but I didn't. I'm sorry. I ignored that.
Okay.
I didn't put 2 and 2 together. And as a matter of fact, I think it was the summer before I had come to Dr. Zamunda. I actually stepped on the glass. Did not know about it, but I did feel wetness under my foot. And it wasn't actually a glass, it was a nail, I'm sorry. I was wearing my sandals and I stepped on the nail, didn't know about it. And I felt the wetness. And so I took off my sandal and there was a bunch of blood there. No pain, was I was actually worried about. The reason that I didn't see the doctor then is because, like I said, I tried to, take care of it myself. That sealed up okay, and I have a little bump there, but it's not like my toe where it got infected and stuff. And yes, there was numbness. There was numbness.
So if I could just chime in, so I kind of want to touch base here. Mr. Flores is a very, very common feeling, right? A lot of people want it to just go away on their own. They're afraid to come and see us, especially knowing that they could lose their legs. And so they avoid seeing their podiatrists or even their medical doctors because they're afraid of what they're going to hear. And I have to tell you, don't be afraid. We are on your side. None of us want to remove your toes. None of us want to remove your legs. We want to help you to get you back on your feet. And the sooner you seek help when you see something bad, the easier it is for us to treat it and get you back on your feet. You have to take these head on and come and see us right away. I can't stress that enough.
Yes.
Thankfully, Mr. Flores came at a time where we could save most of his foot, not his toes, but even now, he was a very hard worker before all of this happened. And now he lost his job because of this. And he tried to work again, and he's having problems even trying to work again, being on his feet all day. Because once we start amputating toes, you kind of lose your normal balance, and it puts you at risk for developing things like open sores on your feet. So it impacted his work life, it impacted his daily life. And so we really want to try and prevent that for everybody. And so that's why we really, really push that you get those routine diabetic foot checks and come in and see us as soon as you can.
Yes.
So Dr. Zamata, does he see you as an endocrinologist also, or does he have a separate team that you work with alongside each other?
Yeah, so that's a great question. So I'm a podiatrist. I do not see him for his diabetes management. We work as a team here at University of Chicago. So he has an endocrinologist, he has a primary care doctor, he actually has a vascular surgeon.
Yes.
That monitors the circulation to his feet. We all work together. Diabetes is one of those diseases where you should have a team. You should have an eye doctor, a kidney doctor, a podiatrist, an endocrinologist if your blood sugars are very poorly controlled and your primary care doctor can't manage it. But we all work as a team to get the best care for you possible. And as a podiatrist, because I think somebody was asking, how do you diagnose diabetes? As a podiatrist, I can't really diagnose it, but there's blood work that you can take, like a hemoglobin A1C, that can determine what your blood sugars are on average over a 6-week time period. There are glucose tolerance tests. There are ways that we can test for you to determine whether or not you have diabetes.
That's great. Thank you, Mr. Flores, for
No
sharing
problem.
your story.
And I did
Appreciate
want to
that.
touch base if I can on a few
Yes,
things, because we talked about a lot with Mr. Flores. So when we talk about open sores, I think that's something that people need to understand. It's not like a cut, it's an ulceration. It is a hole in your foot. These occur mainly in our diabetic patients. We really don't see these too much in people who do not have diabetes.
That's exactly what happened to me.
Yes, so Mr. Flores started as an ulceration. And when you have those high blood sugars, right, because that hemoglobin A1C of 12 is twice what we want it to be. Bugs love sweet blood, right? So bacteria is going to build in the wound because of those elevated blood sugars, because you have an open sore, and that's what winds up making you sick. That's how you get infections. So as soon as you see any kind of even a blister or something that develops into an open sore that looks like a hole in your foot, that's emergent. You need to see somebody right away. Doesn't necessarily mean you need an antibiotic, but we do need to make sure that it's kept clean and that there's special medication that we can give you, and we offload the area so you don't put a lot of pressure on it so that we can close the wounds. And they're difficult to close, and we have to keep you off your feet, which most people don't want to do. But these are the things that we have to do to prevent you from losing your leg. So anytime you have something draining on the bottom of your foot, that is never a good thing, and you should come in and see your podiatrist right away.
That's great. I know you mentioned at the beginning of the webinar about, or maybe it was Mr. Flores talked about gangrene. Can you tell me a little bit about what that is, and is that a result of an ulceration? And
Yeah.
that is.
Yes. So gangrene is when a body part loses its circulation and turns black. Gangrene is not really part of the ulcer process per se. Gangrene is actually a vascular issue. That is your blood circulation getting into your feet. One of the complications of diabetes is that you build plaque in your vessels and they calcify, and then you can't get good circulation into your feet. We need to get blood into your feet to heal things because it carries oxygen and lots of other things that we need. So when I talked earlier on our initial podiatric evaluation, we're palpating those pulses to make sure we can feel circulation into your feet. If you have if you are a person who likes to walk and you find yourself walking a couple blocks and then you start getting pain because you have to sit down, that could potentially be something called intermittent claudication, which is a problem in people who have blocked vessels. So that is a symptom to watch out for. If you used to walk without a problem and now you're getting calf pain, thigh pain when you walk a couple blocks that makes you sit down, you should be seeking advice from your doctors about possible vascular disease. There's a very easy test that we can do. There are blood flow studies where we just take blood pressures down your leg, and that'll give us a number, and that'll tell us if there's any blockage. If there's any blockage, then we send you to the vascular doctors to work their magic to get you some nice circulation into your feet. If your feet are starting to get cold all the time, if they're starting to turn a purple color, or if they start getting very gray and dusky, those are all signs of decreased circulation. Gangrene comes in when the circulation is completely cut off. And let's say you go get a pedicure and they clip your skin by accident and cause you to bleed. If you don't have enough blood to heal that trauma to the tissue suffocates and it turns black and it basically dies, and you get black gangrenous tissue. And once that happens, we have to amputate those parts. And it is also an incredibly painful process. Mm-hmm. So Mr. Flores can attest. Yes. So that is why we check circulation and send you for blood flow studies and get you into the vascular surgeons if we need to. But gangrene is not necessarily a result of diabetes and open sores. It's more of a result of the complications from diabetes on your vessels, causing the tissue to die when it gets traumatized.
Would that have any relation to why toenails are thick or deformed, the circulation?
So actually, no. Okay. So thick deformed toenails is actually probably fungus. Fungus is in the air at like some moist, dark environment. So we all have it inside our shoes. People will develop fungus in their toenails when their nails weaken and they allow that naturally occurring fungus to penetrate the nail bed. And so then the nails are going to get thick. They're going to get discolored. They're going to get, you'll get like flaky things underneath the nail, making them very, very hard to cut. And then it can also change the way the nail grows. So that is different. That's fungus. Now some people can get black discoloration under their nail from trauma. That's blood underneath. That's what we call a hematoma. I have a lot of calls of people saying their toes are turning black, and it's really just that blood underneath the nail from trauma. Usually the nail will either fall off or we have to take the nail off to drain the blood underneath. But that is not gangrene either. So yeah, black can be another color in other areas. That's not necessarily gangrene. But I would rather, my rule of thumb, the way I practice is I would rather you call me and it be nothing than you don't call me and it turns into something. So if you have concerns, just call or email or, make an appointment to talk about it, and, we can alleviate fears.
I've done that.
Yeah. You touched a little bit about somebody wanting to get a pedicure or recommending a pedicure, and what to be careful for, obviously, is getting a cut. Do you recommend your patients to get pedicures on a regular basis? And should they tell the person who's providing the pedicure about their condition, just to be aware?
So I don't necessarily recommend that diabetics get pedicures. I will say, though, that I personally enjoy a pedicure, so I'm sure they do too. And everybody in this, especially this time of year where we're wearing open-toed shoes, people want their nails to look good and they want it painted. So in my low risk diabetics, so those are the diabetics that have good pulses and good sensation, I say, yes, you can get a pedicure, but you always need to go to a salon that sterilizes their instruments. And that means the hot sterilizing, not those blue liquid that they put them in that won't kill off bacteria and fungus. So you want them in the high heat sterilizer. And I also recommend that you tell the pedicurist that you are diabetic. They should not be taking any knives to your feet. They should not be taking those silver cheese grater looking devices to shave down your calluses. They can soak them. They can use pumice stones. They can clip your toenails, but they shouldn't be picking and digging or using sharp instruments on your feet, especially if you're unaware that you don't have poor circulation, because if they do cut you and you can't heal that, that's where we get a lot of problems with pedicures. So if you're a low risk diabetic, yes, by all means, you can get a pedicure. Just be forthright and let them know that you are diabetic.
Very, very good. Another question, why does my heel hurt? Would that be due to circulation?
Likely not. If your heel hurts, that could be a heel spur or something called plantar fasciitis. That typically people will have pain in the morning when they first get out of bed and after periods of rest. And that's more of a ligament problem. And it is not just for people who have diabetes. Anybody can get that. If you are having heel pain and those are some of your symptoms, sometimes just wearing supportive shoes will help you. Sometimes freezing a water bottle, rolling your foot on a water bottle can help. It stretches out that ligament. If that doesn't work, certainly we can see evaluate it and see if we need an x-ray, or sometimes we give steroid injections for things like that. It just depends. But typically, if it's a circulation issue, it's going to start at your toes from the foot from a painful standpoint, or you'll start getting pain in your calf and your thighs, depending on if there's blockage higher up the arterial tree.
Thank you. We have a question here in the chat from Maria, and she says, the doctor told me that my blood sugar is very high. She didn't seem too concerned at the time, but what questions should I ask a doctor about high blood sugars, and how is diabetes diagnosed?
Okay, so I'm not an endocrinologist, I am a podiatrist, but I can tell you that if you have elevated blood sugars, you need to talk to your endocrinologist about why that is. And what they're going to do is probably have you check your blood sugars on a regular basis during the day. They'll also have you do a food diary so that you can log in what you're eating and if maybe a certain food is elevating the blood sugars. They can also tell by time if there is a certain issue. Maybe you have elevated blood sugars in the morning versus the evening. And they can also talk to you about other stressors that might be elevating your blood sugars as well. Diagnosing diabetes is usually a blood test.
Thank you. Another question is, what are bunions and hammer toes?
Bunions and hammer toes, yes. So bunions and hammer toes are those bumpy deformities on your feet. The bunion is at the big toe joint where you see a bump coming out on the side. And then the hammer toes are kind of like bends in the toe, so they kind of look like that. Those are actually hereditary deformities. So you caught them from your mom or dad or grandparent. And in and of themselves, they're not dangerous. So if they don't bother you, we don't bother them. Where I get concerned with bunions and hammer toes on my diabetics is how the foot is going to fit in a shoe. Since the hammer toes are elevated in a shoe, they tend to hit the top of the shoe and it can cause irritation that can lead to ulcerations. Same thing with the bunion on the side of the foot. If you're wearing a shoe that's too narrow, that can also cause blistering and irritation and cause sores to develop as well. So if they become a problem, if they're painful, then we can always surgically correct them. There's really no conservative way to get rid of a bunion or a hammer toe. Again, they're not dangerous. And certainly if they don't bother you, we absolutely do not have to do anything with them. But you do, if you like to get new shoes, you're going to want to wear those shoes for about 2 hours and then take them off and see if you have any red areas. If you do have red areas on your foot, then you either need to have the shoe stretched or think about a different style type shoe. High heel pointed toe shoes, ladies, puts a lot of pressure on the front part of the foot and makes your bunions and hammer toes worse. Not a good idea for long use. People who know me know I like my shoes and my high heels too. I always take an extra pair of flats with me. I wear the high heels for pictures, and then I take them off and get comfortable in my flats. So you guys can do that too.
We have a question in the chat, and they'd like to know how Mr. Flores is coming along after his amputation of his toes and his recovery, and what has been the hardest part of that recovery.
Okay, and I'm going to let him chime in too, but from a physician standpoint, and Mr. Flores knows I love him, but he's given me a lot of gray hair, so I call him my hair now. No, the challenging part.
Just because you care, Dr. Zamata.
It is because I care so much. I think the challenging part for me, and not only just with Mr. Flores, but in general with patients, is when you have a lesion on the bottom of your foot, I have to stop you from walking. That means I have to stop you from working. I have to offload. People have mortgages. People have families to take care of. So it is an unrealistic expectation for me to assume that they can just get off their feet. But if you don't get off your feet and your foot is, and the lesion is on the bottom, it just makes it worse.
Yes.
Right. And then
That's
Mr.
correct.
Flores got into trouble because
I tried going back to work.
well, it wasn't even just that. Part of the problem that Mr. Flores had was we started to, after the first amputation, we tried to get him back walking, and the physical therapist did a little too much.
Yes.
And then he broke down again. And so that is a huge challenge as well. And we see each other on a regular basis. So I become very attached to my patients. And so I understand the stressors that are going on in day-to-day life, but it's very, very difficult because if I have to put him in a boot, his job isn't going to allow him to wear a boot. So it's hard. And then you stop working and now you're home, and it's a lot easier to eat at home, and you're not probably just grabbing anything. And so it's very, very difficult to control the blood sugars. And if we don't control the blood sugars, we really have an incredibly difficult and challenging time trying to heal the wounds and the surgeries.
Right. Now, as far as walking, the first time I didn't have quite my balance, and I actually fell. I mean, I grabbed myself at the edge, but being without toes is a big difference than with toes. I mean, going up and down the stairs especially. I'm starting to learn how to walk again with minus the toes. It feels weird, but it's not, it's not too bad until you get used to it. But in the beginning, yes, it was a little difficult to get used to remembering, listen, you don't have your toes to keep your balance, especially your big toe. And one of the biggest ones was actually going up the stairs. Everybody's used to actually just stepping on their toes going up the stairs. And I kept forgetting that I didn't have toes on my right foot. And when I pressed on it, I would actually slip back down and, oh, geez, here I go again. So I have to remember to step it a little bit further in when I'm going up the steps. Just getting used to the new way of walking. It was the most difficult part of it. And it's really not really that big of a deal once you get used to it. The walking part, going up the stairs, even driving. I'm driving again. I mean, not crazy driving, but I normally drive like a normal driving. And again, I had to get used to knowing that my toes are not there anymore. So I have to make sure that I put the flat of my foot on the pedals instead of my toes, because everybody's used to just using their toes, I guess. And that's the only difficult part, was just getting used to adapting to no toes on my right foot, especially your right toe, which is your dominant, right foot, which is your dominant one if you're right-handed. Going up the stairs, driving, and just walking, that's it. Otherwise, everything's pretty much normal.
And actually, I'm kind of glad that you touched on that. So the type of amputation that Mr. Flores had was a transmetatarsal amputation. So that is where we have to amputate all the toes. Of amputations to have, it's probably the best one because you don't need a prosthetic device. So if you have to wake up in the morning, in the middle of the night to go to the bathroom, you don't have to stop to put on a prosthesis. We also have special inserts that we make with a filler for where the toes are. So it's a little bit easier to wear your shoes, they wear better, and it gives you a little bit of help with your balance so that you can drive again. You are walking and doing the things that you did before, maybe just a little bit differently. But again, I say this not to scare you, but to actually make you feel better that if you ever have to go through something like that, we have lots of things that we can do to make your life as normal as possible after an amputation.
I mean, you can't really tell that I don't have no toes if I'm
Right.
wearing my rag shoes
Right.
with the, with the part in front of the
Right.
shoe. And people look at me and says, I thought you had an operation. And it's this, they amputated my toes. You can't really tell until I take off my shoes and put them together. One's this high and the other one's this light, So yeah, that's, the only thing is just getting used to the new way of walking, driving, going up the stairs, going down the stairs. Your balance is going to be off a little bit, but otherwise, I guess almost normal.
And the goal is to prevent the amputation.
Yes.
Which is why
Yeah.
early, and then we don't have to go through this.
Yeah.
Right, Mr. Flores?
Yes. Stop the mantra stuff. Go see your doctor. Go see my dietitian. Go check your blood pressure, check your diabetes, everything. Because
Prevention's the name of the game.
yes, exactly.
Definitely. And I think for the last few minutes here, Dr. Zamata, if you could just kind of give us a little bit of kind of the, what are the statistics around podiatrist care and people that do have diabetes and the amputation versus the prevention? And, the end goal, like you said, is to stop amputations. So give us
Sure.
of that.
So I can tell you that literature and research studies will actually show that preventative diabetic foot care will decrease your risk of amputation probably anywhere from 60 to 85%. So it is extra important that you actually do get your feet checked, because I will tell you this, 85% of the patients who have a callus will develop an ulceration underneath that callus if they don't have the callus cared for. And a callus is just dry, dead skin that we can shave off. It's no big deal. And so we know that that is a very large pressure point area. We can get you good shoes and we can prevent that from happening. Because I'm going to give you another bad statistic, but if you end up with a below the knee amputation, so that is an amputation, pretty much you lose your leg, 50% of patients will end up losing the other limb in 5 years, or will develop cardiovascular issues within 5 years. And so we really have done a huge push through the ADA, through the American Podiatric Medical Association, through a lot of our wound programs. We really, really want to prevent these, what we call proximal amputations, which are below the knee, above the knee, and try and keep it strictly to just a toe or nothing at all, if we can help it. Because the statistics are scary when we start having to take legs. So we do know that preventative care will absolutely help this. Now, there are cases where no matter what we do, it ends up in an amputation. And so we do have lots of resources out there and lots of ways to get you back on your feet and get you doing the things that you did before, maybe differently, but you can do them just like you did before. So yeah, we absolutely know that prevention is the key to keeping you ulcer free and keeping you with all of your toes and both your feet.
Awesome. I also put in the chat for anybody who's interested to find out more about diabetes and diabetes. We do have our own website, American Diabetes Association, at diabetes.org. And you can find information there. Dr. Zamata, if there is information that you would like to provide, or a website that you might recommend one of your patients go to, or others who are viewing the webinar, please let me know and I can put it in the chat, or you feel free to put it in the chat right now so that our viewers can access that website.
Sounds good. Yeah, I usually refer to the ADA, got to be honest with you, because you guys have a great website, but the American Podiatric Medical Association also has a ton of information for patients and things that you can download and read up upon to get all the information you need to keep you protected.
Okay. And that's American Podiatric
Medical Association.
I'm
Mouthful.
we do have one question, which is really a great question. Why is podiatrist not part of a regular yearly physical?
You mean with your primary care doctor?
I
Probably
would
because
assume that's what they meant.
So probably because they're not specifically trained in the foot. So I think a lot of times they won't look. I can tell you, like, most of the endocrinologists here, and I'm not sure if it's because we work close together or if they're more attuned, but they will have the patient take their socks and shoes off and just take a quick peek. And then refer to a podiatrist. But we're specially trained to look for things that they may not be aware of because it's all we do. So that's why it's just like an eye doctor, right? Your primary care doctor isn't really going to do a full examination of your eye. They might do a quick look and then refer you. But, you know, the specialists, we just take it a next step higher, next level.
Awesome. Mr. Flores, would you like to say any parting words to our audience or any words of encouragement as we close out this webinar?
Well, I would say that anybody who's afraid to get their feet checked, you should get them checked anyway. You don't want to lose your leg, like Dr. Zamata said. I mean, if you lose 1 or 2 toes, okay, but you don't want to lose your leg. Like I was a candidate to lose my below my knee, and Dr. Zamata actually saved my almost all of my leg. I would say, and if you do get amputated, don't give up. I went through the process. You can always have some kind of normalcy by just, you know, keeping your eye on the prize of getting up and don't give up. And there's a lot of people out there, they're worse off than we are. That's the way I look at it. And I'm almost walking normal again. I'm driving again. I'm walking again. And just get your feet checked once in a while. That's all I can say. Get your feet checked. Especially if you have diabetes.
That's great advice. And I'd like to thank both of you, Dr. Zamata and Mr. Flores, for joining us today for the Resource and Wellness Series and Diabetes and Foot Care. And I'd like to say especially thank you to Humana of Illinois for making this webinar possible. We will have another webinar coming up in September. So please be on the lookout for those details. But if any of our audience have questions about diabetes or podiatry care, please feel free to reach out to myself. My name is Rebecca Johnson. And you can find me at rjohnson@diabetes.org. And I'd be happy to answer any questions or can reach out to Dr. Zamata as well. So thank you all for joining us today, and hope everybody has a great afternoon. Thank you so much.
Thanks for having us.
Thank
you.